much is there to achieve yet, but then the pace of the pace of movement is quite good, and it is something really encouraging. And unfortunately, there like West Bengal, Haryana, Uttarakhand, we achieve internationally comparable maternal mortality estimates. So as per the MMEIT report, while the global MMR stands at 211 per 1 lakh live births, India's MMR is 133 per 1 lakh live births, and going further, now with the latest SRS, this number may further go down. So this was a brief, self-assuring, pleasing report which I have just shared with you all. Now some reality check. Now, as I had actually quoted the number, we have more than 27,000 women dying every year in India during the process of childbirth or intrapartum or antepartum or during abortion. Now, comparing it with the previous SRS, we have been successful in averting some 2,300 deaths, but it actually gets translated to 76 maternal deaths per day. And this also means that we are losing a mother every 20 minutes. Now this is grievous, because every maternal death raises a question on our efficiency as a system. It is a blot on us. It is unforgivable. So we have to find those missed opportunities where maternal lives could have been saved. We have to find out what all went into the death of any mother, and besides probing into those socio-economic factors which are contributing to these maternal deaths. Now talking about the state of Jammu and Kashmir, since the sample size is small, we have an estimate of around 2.2 lakh pregnant women annually in the state of Jammu and Kashmir. So the sample size is not sufficient to actually come out with a calculation of maternal mortality ratio. But an estimate of the deaths which have been reported for the state of J&K, the deaths which were reported and captured on the portals, and as per the data and the number which we get from the HMIS and as per the physical report from the state, number somewhere hovers around 100, but we strongly feel, and as per the discussion also, that the numbers may actually be more. And why the number has to be more, this I'll come to. I definitely would like to throw some light on that also. Now, as per the, again, going by the review part, now MDSR process as such is a continuous surveillance process wherein we are reporting the maternal deaths, identifying them, and doing out a review for those maternal deaths as to what went into this specific maternal death. Now for the state of J&K, what we have seen is that the review part can very well be strengthened big time, because what we are seeing is that 60 to 70% maternal deaths are being reviewed. Also about the quality of review, unfortunately what we see is that more than 80% deaths are being delegated in as others. The causes of death is going into the others column. So again, that is something which we can really improve, and something which we can really work upon. We can educate our service providers. We can really, find out the cause of death. And this is the reason why recently we have come out with the MP-CDSR software, which is an extension of the MDSR guidelines launched in 2017. We had a very good detailed discussion in the morning regarding this particular thing. So again, not only about the reporting and review, but there are few other observations also as far as J&K is concerned. So as I've already said, that we need to find out those hidden or unreported maternal deaths. Now, at this juncture, I would like to appreciate a few of your districts like Bandipura, Bandgam and Doda. They have actually begun reporting maternal deaths, which was not happening earlier. Also, Kathua, for the district of Kathua, the reporting has improved. Again, this is something appreciable. You are at least able to find out and trace and report those maternal deaths. The review part, as I said, definitely needs improvement. And there have been districts from where the reporting is not there, there is something amiss which we strongly feel, because for some of the districts here, we have high home delivery pockets, and we are sure, we know very well that any home delivery cannot be a safe delivery unless it is conducted by a skilled birth attendant. And there are, geographical challenges for the state of Jammu and Kashmir, the difficult terrain, the geographical, the challenges, the climatic challenges. So there may be instances where the deaths, the pregnancies are not even getting reported. So what to talk of the deaths of these pregnant mothers? So maybe those are the areas where we need to strengthen and where we need to pick up. The other thing is that this deaths happening in the transit. Now this is a situation which is there in every state of the country. The deaths in transit are not, being captured, and so this is again one area. This becomes a grey area where I think we need to work hard, and the ministry has come out with this MT-CDSR software wherein there is a provision of reporting the deaths in transit also. So it was actually with this idea of enhancing the reporting of maternal deaths that the ministry came out with the first responder incentivization under Suman, and to make the people aware, the community aware, and even the healthcare workers aware that reporting of maternal death is actually non-punitive. And that incentivization is a means of encouraging that maternal deaths have to be reported, and no disciplinary action would be taken against any of the person who is reporting it. Now, it is the way the NHM guidelines have been framed, and the 2017 MDSR guideline also, after this 2017 MDSR guideline, there have been introduction of newer programs under NHM also, and these programs are actually interwoven around, and they aim to strengthen the issues under the 3 delay model of maternal death. So the determinants, the causes of maternal deaths, they are very well being addressed under the various programs under NHM. And for the state of Jammu and Kashmir, it is well endowed with more than 10,000 ASHAs and 4,000 plus ENMs. And so that word has to go around in the community about the various schemes and programs under maternal health that IC and the behavior change communication part that has to be taken care of by these grassroots level workers, field workers, which I strongly feel that at our field visits also we somehow found that they need a kind of a reorientation or a training, so that particular thing can very well be taken up so that the message percolates deep in the society. Again, the matter of transport, this remains a concern for the state here, considering the difficult remote areas also. And I was happy to see in the morning when the announcement was made regarding those 102 transport vehicles under JSSK, 107 plus 95 vehicles under JSSK have today been added to the fleet of existing ambulances. So that is encouraging, and I hope that we are able to actually ease the transport for our women who require this timely transport. As it was discussed in previous session also, that that transport facility is not available and the woman is dying and she is not able to reach the facility on time, or maybe she is reaching and she ends up getting operated, or the kind of morbidity is happening in the terms of high risk pregnancy. Again, the programmatic part, the JSSK, JSY, PMSMA.
We'll come to the programs
sure.
And policies.
So I was coming to the programs only.
Okay.
All right.
Okay. I'm so sorry. Due to paucity of time, over to Dr. Anil Mehta sir. Sir, since you are one of the leading OB-GYN specialists in J&K, please put your thoughts on maternal mortality and its determinants. Secondly, the delays that may lead to maternal death.
When I came here in the morning, I met few friends like Dr. Shafi and Dr. Adil and other people, and looking at the magnitude of people who had come, I said, you are doing a mammoth job. So I'm so happy that we are touching a very, very sensitive issue by the deliberations and expert opinions by the policymakers. Unfortunately, the delivery, which I over the years have realized is never a medical issue for the patient as well as the attendants. It is not a medical issue. They think that it is not a medical science. It is more of a social issue. They come to deliver, they come to celebrate the occasion, and they come to, it is the futuristic goals, like the baby will be born and what will be the name of the baby and how would they celebrate the whole thing. But suddenly what happens is that because of the unfortunate circumstances, the mother loses life. So this is most difficult thing to explain to the attendants, and it is very difficult for the gynecologist or the obstetrician also to digest it. The person who loses his wife may get married again after 1 or 2 years, but the gynecologist probably remains shocked for whole of his life. This is what is my experience with the maternal mortalities. Madam said that we are losing one woman every 20 minutes. I'm quoting Dr. Malcolm Potts, who said in 2005 that we are losing one woman every minute. So I think we are doing remarkably well and moving in the right direction, that we are losing certainly lesser number, but the goal is still very far away. For such an event and a social responsibility, a young woman who is fulcrum of a society, if she loses of her life, the whole family is disturbed. And mother is the most important asset to make healthy nations. Ian Donald there's a book of obstetrics by Ian Donald, and Ian Donald said that World War I is over, and we are so happy now that we are not seeing one obstetrical patient every minute. We are spending more time with the patients, and we are understanding their problems much better way. But in India, we still are facing a problem of seeing probably one patient in 1 minute in few of these situations, and that is why probably we are not able to understand their problems in such. It doesn't happen it's not just a single event that mother loses life. It is a continuum. It is a continuum. This continuum starts when probably she becomes pregnant. Now girls are educated, they are well informed, they know, even in remotest possible areas, they are well informed by the TV, by the print media, by the local administration. They know that there is an importance of going to the for antenatal care. So I just tell this story to all of my people who I discuss the maternal mortality with. I say that let us take a story of a girl who is 24 years old, recently married, modestly educated, to understand that it is important to go for antenatal care. She has illiterate in-laws and a manual worker husband. Now, she, against all the wishes, superstitions, all the myths of the elders of the family, she manages to go to the healthcare center. She keeps on going there as per doctors tell them. As Dr. Maisuma said, that she goes to the hospital religiously, she repeatedly goes there, but her BPs are not checked, or checked by a faulty instrument, or probably a person who is not trained enough to see the BP, and she said, okay, 128 is the standard tagline there, right? And this patient keeps on going for the number of times the doctor tells. Then suddenly this woman becomes around 24 weeks, and then she is neglected, BP remains the same, and suddenly, when she turns, and she feels at night that she's having pain or she's having headache, she's in a remote area, she goes to the hospital, doctor is not there, because of some doctor is on leave, the hospital is closed, remotest hospitals, night services are usually not very good. So she's referred to another place where she goes, and she's checked that her BP is very high, she's having headache, she's having altered liver enzymes, and she's told that she starts throwing fits, right? And then she is referred to a tertiary center, and the transportation, the non-availability of ambulances, non-availability of the medical staff. She reaches a tertiary center, suppose she reaches Jammu, and then she has to wait because there is a long line of patients who are awaiting the management. And then, waiting there, she gets another fit and another fit and another fit, and she dies. And everybody says, had this patient come earlier, we would have been able to save her. This is the usual line which is said that, true, had she been referred earlier, she would have been. Now, what are the scenarios which come to us? Are one is apathy of the family. Second is financial condition of the family. Third is myths and superstitions of the family. And then the infrastructure, then long distances, then lack of medical facilities, and then coming to the hospital, the huge rush of patients. And these are, if you look at the story, most of the things will be explained to you. Now, not that patients are not hypertensive in the advanced countries or developed countries. Not that they don't have problems there, but they are much better prepared to handle these situations, and with the result that in developing countries the loss of lives is much more as compared to the loss of life in developed countries. So the scenario is like this: if it is the mortality is on a decline, it is a very good welcome sign. Developed countries are doing much better; their mortality rates are much lower. In developed countries, Scandinavian countries like Norway and Denmark, they are doing much better. Their mortality rates are less than 10. But the situation in the developing countries like Southeast Asia, there are countries which are doing much better, like Sri Lanka is doing very good amongst Southeast Asia. And in India, if you see, there are certain Hindi speaking areas which are doing very bad, but then there are areas like Kerala who are doing very good, and what policies they have adopted to do well, we must follow them and understand them. There is a irony is that today there is much advancement in the technology. And we are doing IVF, we are doing stem cells, and so many things. But still, we have to discuss the maternal mortality in 2022. That is that is the irony of the situation, but it is a very serious issue. Now, I talked about the factors which can lead to the maternal mortality, but then there are certain causes which we divide into three. We divide them into direct causes, there are indirect causes, and there are incidental causes. Direct causes, we have famous 5, and hypertension is one, then bleeding is second one, and then sepsis is there, obstructed labor is there, and other causes. Then there are certain causes which are aggravated because of the pregnancy, like liver disease, like heart disease, or other diseases which are anemia. Anemia of the pregnancy is also very important. There are certain incidental causes which are not aggravated by the pregnancy, but myocardial infarction, fevers because of medical causes, or suicides or accidents. These are the causes which are very rare in pregnancy, but they are not because of the direct consequences of the pregnancy. So this is the whole scenario as to what are the causes of the maternal mortality.
Thank you so much, sir. Sir, you said we are still hearing about MMR, maternal mortality, but hope by 2030 we are hoping we will not hear this maternal mortality in India. We will be talking about improved maternal health and not about maternal mortality.
Yes, madam is very right that
mortality should not be there. Right?
Yes, the irony is that all these deaths are preventable to very large extent, and no woman should die of those causes which can be prevented.
Yes, sir. Thank you so much, ma'am. Dr. Shanta, ma'am, POXI is one of the leading OB/GYN organization, and it considers reducing the maternal mortality as one of the primary missions. So, ma'am, throw some light on what are the contributions of Foxy in reducing the maternal mortality, because you have been working with Government of India also for the same.
Thank you, Meenakshi. Congratulations to the whole team of J&K for this fantastic MCH Conclave. And to put on record, this is one of the very few meetings I have been sitting from morning to the last session in the hall. Though I'm there for every week to 3 conferences and I hold conferences. I think because the conversations, the dialogues are so very interesting. I think that's very important. And yes, Foxy's mission is primarily to reduce the maternal morbidity and mortality. And this year, as the President, my vision and mission has been Foxy for all always and Dhira Stop Violence Against Women. Foxy for every mother to prevent preventable maternal morbidity and mortality. For every woman to be able to live with Dhira to say no to violence against women. And Foxy for every Foxyan to be able to practice with dignity, with protocols. Now this vision and mission is all focused on women's health. To reduce the preventable maternal mortality and for the woman, when we say no to violence against women, because it is her sexual and reproductive right, it's her right to have an healthy life, her right to have the access to the maternal care, her right to live even after being pregnant or having problems. So these are the issues which we are dealing with. And friends, now we're talking about the SDG goals. Now, when we're talking about the MDG goals, how many of us actually knew what MDG goals was till about 2011, 12, 13? Only when 2015 was coming, then everyone started talking about MDG goals. And that was a time, I'm sure, if many of you would have asked any gynecologist, Padmini will agree with me, many of the gynecologists, maybe more than 60-70%, never knew what MDG goals were. Why is it so now? Why did the MDG goals fail? Whatever may be your infrastructure, your policy making, your governance, your all the things put together, but the end point is, it is going to take shape and the fruit is going to come when the obstetrician gynecologists who are delivering care are aware of it. But they are partnering and they are doing it. So the optimal outcome only comes there. That's one of the reasons, I think, because for the MDG goes to, they didn't realize the importance of the OB-GYN as a specialist that much. And maybe the OB-GYNs also did not react that much. But that could be one of the reasons, and when we moved on to SDG goals. When you look at Foxy as such, from long back, there are many people who have been doing so programs, especially the emergency obstetric care project, which was going on in the early 2000s, where Foxy has partnered with the Government of India and doing the training of medical officers for emergency care, for handling PPH, for doing the basic life-saving skills, for emergency C-section in those areas where they didn't have qualified gynecologists or obstetrician services. So it started with that in the late 90s and 2000s when it took shape. And over the years, many programs, CMEs, workshops, towards actually making the OB-GYNs and the medical officers who are involved in delivery better equipped with the skills and drills of saving the patients in emergencies. And we had some scheme in 2013, it was helping mothers survive. So where the training of the OB-GYNs and even paramedical staff, we used the Mama Natale and those gadgets with the ladle and all. Foxy also invested in 100. We did a lot of workshops, more than 500 workshops across the country. And actually over the time we saw that the number of women dying from PPH reduced and it took the second place. So in the beginning it was the biggest kid killer, and of course till now we have not been able to conquer anemia. That's also contributing. So a lot of CMEs, health camps, and trying to see how best we can take care of these aspects. And then over the years we have had skill-based programs for our paramedical staff. So we have started this Manyata. Then in a lot of states, especially Maharashtra and all, there was Lakshya Manyata. These were the collaborations. See, the Government of India is doing fabulous job. You all are targeting the public sector still now. But you have to remember about 50 to 60% of the care is delivered in the private sector. So we cannot achieve what is the best of health or the maximum output unless the private sector is involved. So we were trying to see where The private sectors were not trained. So you need to train the paramedical staff of the private sector. The government is doing fantastic training for the government sector, the paramedical staff. You take the ANMs, you take the nurses, midwives and all, sit there sitting and listening. So the superb programs. Extend those programs even to the private sector, which you all have. There are some programs and we are also trying to do that. We have started this Naipunya and there's so many programs if we start. Now of course with a lot of collaboration from WHO and so many other organizations, we are all working towards trying to see how we can reduce the burden of PPH. So being the FIGO, we know FIGO and FOXI are working together. There are so many projects. We have got a huge project of PPH, reducing the burden of PPH. We have got we have a lot of committees. We have got the Safe Motherhood Committee, the Family Welfare Committee, the Public Awareness Committee, and most important is even contraception. See, you cannot address the issue of maternal morbidity and mortality unless you touch the woman's sexual and reproductive rights, unless you talk about the contraception, unless you talk about the fertility control. And PPIUCD project, this is also a very important project. The FIGO project, which is partnered by FOXI. Now, PPIUCD is not just putting in PPIUCD, IUCD as soon as the woman delivers. Now, that is actually targeted in reducing the maternal mortality and morbidity. This woman who goes out of the hospital with an IUCD, at least you are assured of the spacing for those 2 or 3 years. That is a time gap where the woman will recover out of the mishap of this pregnancy, the anemia and the other issues, so that by the time she actually comes back, she's in a much better shape. And that will also contribute to reducing the maternal mortality. So when we are talking about family planning, family welfare, we are not talking about either the government policy or a religious policies or an individual's attitude. You are actually looking at maternal health. We are looking at the maternal morbidity and mortality. So these are the very many aspects which will all contribute for reducing the maternal mortality and morbidity. It is not overnight that government has achieved this low level, and I'm sure the way it is going, we will definitely achieve much lower. Now there are many states who are looking at trying to reach the single digit MMR. But that will be possible only with keeping the private sector into confidence. You take them into confidence, work together. It is not a one-upmanship, I am the boss. I am going to tell you, you better listen. I think that will not work. You have to work in tandem. You have to work in collaboration. You have to work with unity, and only then we will be able to achieve. So I think that is what is the right, situation now where we see now. See now at this, there was a stage about 20 years back where FOXI was not involved at all much in many of the policies. But over the years we have seen how all of you have been involved in the FOXI, because you know that we are the via media for our gynecologists and the government. And of course, as FOXI, I am not only a president for my private sector doctors, even my public sector doctors are FOXI members. So, who is contributing to the reduction in the maternal mortality? End of the day, my obstetrician gynecologists, my FOXI members, they have to be commended, they have to be appreciated. And definitely, that will go in a long way to reduce the maternal mortality rate. Taking them into confidence, in making them a partner in trying to deliver the care is where we will achieve the best. And I'm sure now SDG goal achieving is not a big problem. We will definitely achieve it. And in fact, Dr. Padmini, we just were mentioning, Dr. Yasin, I have to put on record. See, we used to think Jammu and Kashmir high hilly area, very much high with so much of turmoil. We don't know what the situation.
Decrease mortality rates, and that I think it's very good, and we should have a good audit in our hospitals. Once a patient is received, we should be able to give them good quality care, and knowing that we are accountable to the people, we are accountable to the attendants and to ourselves, and we should take all the measures for prevention of all sorts of complications. We should do surgeries and other things, keep good records by ourselves, and give them good quality care. And we should educate these patients regarding the contraceptions, inter-pregnancy intervals, and prevent the anemia also in these patients. And high-risk patients should be seen by the other specialties also.
Thank you so much. We have with us Dr. Vanna Sinha from Apollo Hospital. She has joined virtually. Okay. Let me remind you all. Hope you all are tweeting with the hashtag MCH Conclave JK. Further, in order to end the preventable maternal deaths, accurate information on how many women died, where they died, and how they died is essential, as ma'am also said about this. So, currently this information is inadequate. Maybe because of so many reasons. Maybe healthcare professionals think ये बहुत unimportant task है, हम record करेंगे कि उसका पूरे notes record करेंगे, place of death, कैसे उसकी death हुई, cause of death, and causes जैसे मैम आपने बताया कि उसमें causes में more than 60% of during 2021-22 more than 60% of causes in J&K maternal deaths, more than 12% were this PPH, but more than 60% were these others causes. Yes, ma'am. Actually, during 87 deaths occurred during 2021-22.
Ma'am, let's not make it a review meeting because we can have a discussion later on that. But we quote the data that the state puts in, and the data speaks for itself. Actually, that the whole system has to be streamlined, the reporting, the surveillance, the review part. And that was one of the reasons that we came out with this MP-CDSR software, for which, we really honestly appeal to the state of J&K. Sir is sitting right in front of me, that kind of an orientation and the rollout has to be done. And, in fact, those transit deaths can very well be captured, as I mentioned earlier.
Yeah, ma'am. Ma'am, I was about to ask you, request you rather, what MP-CDSR software से हम लोग किस तरह से जो maternal mortality को किस तरह से reduce करेंगे कि those causes जो आते हैं वो other causes ज़्यादा आते हैं. तो how we are going to MP-CDSR software से किस तरह से हम लोग इसमें improve कर सकते हैं. And also ma'am, MDSR software के MDSR strategy के implementation में क्या क्या challenges हैं उसको हम कैसे over कर सकते हैं, because that is also very important.
See, challenges की मैं अभी बात already कर चुकी हूँ, दोबारा से मैं एक बार बता देती हूँ. जैसे जो हमारा observation है from the national level, what we are seeing is, first of all, the reporting part, as I said, those deaths in transit or maybe those home delivery pockets, those have to be picked up, because the more the number of women we pick up, we can actually find out the reasons what went into their deaths, and those corrective actions at the level of strategy making, policy making, or maybe the orientation of whatever the root cause, that can be actually be corrected. So that is one part of it. And the other thing is that this MP-CDSR software, the genesis of this software was to make a uniform system for reporting of the maternal deaths. This is part one. Now after the reporting, and that is going to be a real-time continuous surveillance mechanism which will be across all the states of the country. इसमें आप ना सिर्फ national level पे बल्कि state level पे भी, district level पे भी you can actually monitor that immediately आपका data enter हो रहा है, and you can see that this death has happened in this particular area, this particular block, or this particular village of the state. Now the second thing comes thereafter is the review part. Now there is no doubt in that the review mechanism in our country is still, at the national level, I'd say it's touching 70%. For the state of J&K, what the data reveals is around 66%. So again, that review part is lacking. Why a review has not to be carried out it has to be carried out for a single death, every single death. The cause has to be found out, right? Now, 86% of the deaths you are saying going under others. What do you mean by others? So just to counter that thing, because we don't know what is other. So, there is a definition of the causes of maternal deaths, and that others is a broad thing. All kind of causes for which the cause cannot be ascertained, that goes into others. Now what we are doing is we are introducing this ICD-10 classification of maternal deaths, and it is a very crisp classification of the deaths which any person who is filling a form or who is putting in data in that software, he can, at a glance, he can come to identify what exactly went into the death. He can actually make the entry on the software, which is, I don't think is as cumbersome as filling the papers, finding out, or writing, scribbling with the pen. It is much easier thing. And you know, when you are actually getting to know the cause of death, you can actually take the requisite actions, whether it was a high-risk pregnancy, whether if there was any pre-existing medical condition that triggered a kind of a cardiac failure and that led to the death of this particular woman. So those causes can very well be ascertained, and you know that those corrective actions can very well be taken. Then the thing comes that you know you can actually assess at the district and the state level how your facilities are doing, whether the community-based reviews are happening or not. And I think not many, or I don't know, people are actually not aware that even if a death is taking place in a facility, that community-based review has to be done for each and every death which is happening in the facility. So this, again, this part has to be strengthened, because you know, facility level death, we can come to know about the medical causes of death. But what about the delay 1 and delay 2, as sir rightly mentioned? So that verbal autopsy part for any facility-based death has to be carried out. So this is the whole, this purpose of bringing out the software, so that you know this actually gives you alerts. The software, for the state of J&K, we have already created login credentials. That orientation is yet to happen. I am repeating that. And you know, once the system is in place, those alerts will be there at the level of block level, at the level of the district, the facility level, and at the level of district level. So there is this whole cascade of alerts which will be generated. So suppose if a death happened in a facility and the community-based review has not happened, so the concerned block medical officer will get an alert. So we have created such systems so that you know no death is unanswered. This is what we are striving for. So this is what this MTCDSR software addresses.
Thank you so much, ma'am. Dr. Shanta, ma'am. You talked about Manyata and Lakshay Manyata also. So, is Foxy could take a leadership decision in educating the gynecologists regarding this MDSR or for advocating the maternal death audit?
Actually, Foxy is definitely advocating on this MDSR, and in fact, you know, we are sending some of, like the CEFOG and MFOG and FIGO are also doing some programs where we also are sending our members for that program. And many of our Foxy members who are in the public service, in the government service, are a part of these, and we are utilizing their services to educate the people who are in the private sector. And especially now the option criteria, you know, when you're talking for the C-section and all, now that's been advocated for even the private sector. It is not only the public sector. See, every obstetrician is responsible. Every Foxian of mine is responsible, be it in a public sector or be it in a private sector. Because end of the day, both of them are taking care of mothers. Both of them are responsible for the maternal health and well-being. So definitely yes, and audit is something, maybe probably a few years back, the accountability was not there because we didn't have a robust system. But now our system is so robust. Now nobody can say, okay, I am running a private nursing home. Why do I have to answer? Somebody told me I am in a private nursing home. Well, you are asking me about the cesarean section rate. I said, you are a private nursing home person, but your license can be cancelled. Your hospital can be closed. You are responsible, so nobody can talk like that. So every obstetrician gynecologist is responsible, and we are also trying to see what best we can to train our Foxy members in these areas. Previously, I have to put on record, 10 years back, when I used to speak for orations and all, I used to always speak on maternal health and all. The main hall, it used to be quite empty, nobody used to attend the programs, but now I have seen a change that even when the topics of maternal health and these topics are happening, there are people and the halls are full. So people have realized that these aspects affect the practice, and as much as learning the skill of laparoscopy or learning the skill of an any other ultrasound or any other thing is as important.
Thank you so much, ma'am. Thank you for your valuable information. Now the house is open for discussion. Questions from the audience. We'll invite questions from the audience.
If anybody has any question, please feel free to.
Actually yielded results or not, because we've been very religiously, inducting them, but we're not really sure because the referrals are still happening. How do we, check whether they are getting it?
So, sir, as far as BMOC training is concerned, it is a must, and we really advocate that. It is kind of after the induction training of a medical officer, a BMOC training is a must because it is basically orienting and it is kind of a skill providing training for a newly inducted medical officer. As far as CMOC trainings are concerned, definitely the trainings have been a boon, but not uniformly for all the states. There are few states which have benefited out of them, so it's up to the state. What is the perspective? What is the the background situation in the state as far as the provision of emergency obstetric services is concerned? So it's basically, and the other thing is that after the training part is over, whether the doctor is given that opportunity and whether the doctor actually utilizes that opportunity to go ahead and actually practice and provide those obstetric skills which he has done over these trainings. So that part is also very important. Besides the training, the intent is very important. So there have been states, we have the examples of these, like, so they have actually gone ahead with the CMOC trainings, but then again the attrition rate is high. So, those trained candidates, they have been providing trainings. Some of them, they were not that confident. So in these trainings, review meetings with the state, so we suggested that they are a good resource for you and they can very well be utilized by providing a reorientation training. So it's a state's perspective also.
Sir, I have to add a point here. A few years back, 10 years back, in the city, in a private medical college, there was one application came for a job in the medical college. I said, what's your training? No, I have been trained for this emergency obstetric care. And I said, you have been trained to take care of women in the periphery, not in Hyderabad, in a private medical college where there is no need for your level doctors. So that has also happened. There are many places where these people are actually starting a private practice and those have been happening. And so this has been noted quite many times, and I'm sure all of you also know that, but then...
Thank you very much. Now I request our Mission Director, sir, to please come on the stage and facilitate our panel.
Can I just add one last word for the day,
yes,
the winding, concluding comments. So I totally agree with Dr. Chanda Kumar that, that coalition, that collaboration between public and private is a must if we are talking about health of women, particularly the maternal health perspective. And what I strongly feel is that, madam, as you have given those encouraging thoughts to all the gynae ops present here today, and those were, coming from you, it's really encouraging and motivating. So I would rather, like to see enhanced reporting of maternal deaths from the private sector, which remains a perennial issue throughout the country, specifically not for the state of J&K, but for the whole of the country. So that thing has to be enhanced from the private sector, right? The other thing is, madam, we need your contribution and the contribution from the gynecologists for our PMSMA program. I hope you are aware that now we have come out with extended PMSMA. The time when it started, there was a huge fountain show and there was, this participation from the private sector. But, over the years, somehow I feel we have lost track. It's our Sarkari doctors who are actually, conducting PMSMA clinics. And, when we are talking about maternal mortality, bang on, we have to target our high-risk pregnant women. And high-risk pregnant women, their identification can only be done by an obstetrician gynecologist, as you rightly said. They are providing the services. Now, in those deprived areas, we do not have the privilege of having a gynecologist in every facility of our country. तो कहाँ से लाएं? तो आपकी तरफ हम उम्मीद की नजरों से देखते हैं कि हमारे जो हाई रिस्क प्रेगनेंसी का डिटेक्शन है उसमें आपकी तरफ से कुछ सहयोग हो जाए. Thank you.
Thank you. I can't help but say a point.
Yeah, please, ma'am.
All my foxy doctors are very happy and ready to help, but वो थोड़ा प्यार से बोलना मैडम. आप लोग का थोड़ा प्यार बढ़ गया तो हमारा प्राइवेट सेक्टर लोगों को जरूर you will get a good number of people who are going to be involved with that. Dr. Sikdar, I can see the smile on your face.
Thank you, ma'am, for your
Thank you
valuable
all the panelists for sharing your wisdom and illuminating us with your views. Ma'am, today, ma'am and sir, today we are wrapping up, but NHM assures you that it won't be wrapped on today only, but action will be taken. Thank you so much.
Thank you. Yeah, please outside, everyone is requested to have tea outside, please. Very right. Dignitaries are also requested that to please proceed for ferry ride, which is outside.